And today with Dr. Mahmoud Saidi.
Thank you so much for your patience, for your listening, and I hope you're taking important
Fellowship
points.
in US. Yes, and right now we are going to give us. He's going to give us like very amazing presentation as we expect from him. So he's right now there. Let's start with
السلام
Dr. Mahmoud.
عليكم ورحمة الله وبركاته.
عليكم السلام وبركاته.
How are
Take the
you,
mic.
big boss?
الله يحفظك يا رب ويبارك فيك.
نور.
الله يرضى عنك يا رب. تسلم والله. So the mic with you now. شكرا.
Okay.
Thank you. Okay.
As a beginning, I want to thank all the RadMe team and this amazing day, amazing lectures, especially the last one, Dr. Mariam. A really very nice presentation and very important topic, especially the last one about the silhouette sign. It is very common to see in your day-to-day practice and also in the exams. Really, it gave us a very good presentation. Let's start by the final talk. We will have a brief talk about the updates in the tumor classification, in the CNS tumor classification. Let's go directly to the lecture. We have two parts. We will give only the first part today about the diffuse gliomas in the brain, in the adult and in the pediatric age group also. The second part will be about the rest of the CNS tumors other than the gliomas. First, we will talk about the few concepts as introduction for the lecture. We will talk about the classification system, how it is going on, and the methods and the techniques, how they classify the tumors. We will have also highlights on the molecular diagnostics and the genetic testing and these issues. As a radiologist, you need to know a little bit about these things. And for the introduction also, we'll end by the grading and how they grade the tumors. For the principles, the tumor classifications is not as the periodic table. If you remember the periodic table in the chemistry in the high school, it is not like that. In the real life, in the real situations with the patients, we are trying to classify the tumors as much as we can, but every time we can face a case that has a mix of the classification or has undetermined types, and this is the real life, and we will try to do our best for the patient care and for the treatment plans. There is an organization, is the WHO. This organization is giving the classification for all the body systems, not only the CNS. And this organization is the international reference standard now. And she gave the editions in fixed order. I think every 5 years they have a new edition for the tumor classification. And they classify the tumors and try to gather them according to the pathologic characteristics and the natural history of the disease, and the patient demographics also according to the age or the gender preferences. This classification helps us in many ways. In the practice, it helps the clinicians for the prognostic predictions of the disease, and to choose also the specific treatments according to the tumor types, and also for the future, for planning for the future, how they design the clinical trials according to also the perspective of the disease and which type of the tumor they need to know more about it, and they need to do more researches about it also. And there is a small subdivision of this famous organization. It is named as Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy, not official WHO. because as I told you, the WHO only give the additions in a timed manner every 5 years or so. Uh, and now, there is a huge increase in the knowledge and the investigations. And every mean and while there is a new types and the new things they can discover between this 5 years edition. So there was a need to have a certain updates, yearly updates about the new techniques or new tumors that have come between these 5 years. As example that of the changes of the tumor types or classification systems according to the molecular markers and according to the genetics. These brief examples, we will talk more about it later in the lecture. As the glioblastoma, there was two types before of the glioblastoma according to this genetic mutation, the IDH gene. There was two types, a wild type and mutant type, and in the past it was considered both of them as a glioblastoma subtypes, but now all the glioblastomas are only having the IDH wild type, and the mutant type, they reclassify it as under the astrocytoma, like what you saw here. And also there is a new families introduced to the classifications. We will talk about it also later in the lecture, the pediatric types especially. The methods of the classification, how they detect the mutations and how they do the genetic testings. You need, as a radiologist, to know a brief thing about these items, as if you are in a tumor board or you are attending this very important meetings, the multidisciplinary teams. You need to know a brief about the genetics and the molecular alterations and the mutations in order to get in touch with them in the discussion, and also you can give them your opinion from the radiological point of view. We have a lot of genes now introduced. This the most important or the most common genes that they already know about, and using them also for the tumor classification. The techniques also, there is many techniques to detect these genetic alterations. You can know a brief about each type, the fluorescence hybrid, the genome wide copy, the next generation sequencing panels, and the methylation array. For the DNA methylation profiling, also it is widely used now, that they have a genetic map and they compare the genetic maps of the patient to this standardized one to detect how much it looks like, or what are the difference and what is the percentage of the difference. And also this another example of how they use the molecular diagnostics in the classification for the oligodendroglioma tumors, even if the pathology and the radiology is not giving us the common picture of the oligodendroglioma, but in the genetic testing, they found this type of mutation of the IDH with co-deletion of these genes. They consider this tumor as oligodendroglioma, even if it doesn't have the common histologic features. And we will talk also about these things. Sometimes, as I told you, it is not solid facts. It is not like the periodic table. Sometimes we, due to the technical errors or due to that there is a new subtype or a new tumor we didn't see before, and they assigned it to not otherwise specified or not elsewhere classified accordingly to the situation. For the grading, they are using the Arabic numerals now, 1, 2, 3, 4, instead of the Romanic ones. And they also added a specific name. This is the CNS WHO grading system, is exclusively for the CNS tumors, because as I told you, the WHO this organization is giving grading system for all the organ systems. Again, they did in 2021, the last edition about the grading systems, they deleted some subtypes and they introduced a more wise classification. As example, in the meningioma, it was many types of meningioma, the atypical meningioma, the anaplastic meningioma, the malignant meningioma. Now, there is no need to name the meningioma itself, but we graded the meningioma types. So all of them are meningiomas, and there is certain grades under these types. Okay. Also, this doesn't imply that multiple grades option exists for all tumor types. Not all the tumors have the same grading from 1 to 4. Some of them never has grade 4. Some of them always have grade 1 or 2, and like that. And let's go for the radiological point of view. We will talk, as I told you, the first part will be only on the gliomas, and we will talk about the adult types and the pediatric types. The adult will include astrocytoma, oligodendroglioma, and glioblastoma. The pediatric type, they have subtypes, the low-grade pediatric gliomas and high-grade pediatric gliomas. And this is not the only types that they know. All every type or every subtype has also a subdivisions underneath it, but with in a radiological point of view, we don't have this much information about each subtype of them. We'll start about the adult gliomas. The common ones are the astrocytoma, the oligodendroglioma, and the glioblastoma. And underneath each one of them, it has a certain mutation type. The IDH mutant, as I told you, it was under the glioblastoma, but now it is under the astrocytoma. The oligodendrogliomas must have this co-deletion of these genes, even if there is absence of the common features in the histology or in the radiology. And also there is grading under each type, the grade 2, grade 3, grade 4, and accordingly also each grade has a much aggressive behavior and much aggressive treatment according to that. And let's see, we will start by the astrocytomas. This type of mutation, it is IDH mutant without the co-deletion of these genes, because if there is co-deletion of these genes, automatically it will be oligodendroglioma, not astrocytoma. The grading is primarily based on the histology. And if they found another mutation that for this gene also, it is always correlated with poor prognosis, and always it have a grade 4 classification of the astrocytoma if they found this genetic mutation also, even without the histologic evidence of the aggressiveness, because it will be aggressive after that. Okay. For the astrocytomas, there is acquired co-deletion of this gene that is responsible for the poor prognosis, and they found that it could happen also following the radiation. The radiotherapy has also hazardous side effects. The most important one of them is this genetic mutations that happen after the radiotherapy. Radiologically, the most important sign for the astrocytoma is the T2 flare mismatch, that the lesion is hyperintense in T2, and when we see the flare images, we find that the periphery of the lesion is having a hyperintense REM. Not all the lesion, only the periphery is having this flare hyperintensity, and it is highly specific for the astrocytoma. The tumor enhancement also is somewhat related to the higher grades of the tumors, especially the grade 3 and grade 4. And this is an example. You can see here the astrocytoma in the right temporal lobe. This is the T2 is hyperintense, and in the flare you can see the hyperintense REM sign beautifully. And for the enhancement, as I told you, that it is related to higher grades of the tumor. The second type of the adult gliomas is the oligodendroglioma, and as I told you, this specific genes co-deletion is specifically related to the oligodendroglioma, even if there is no sufficient histological evidence that it is oligodendroglioma. And this was the common histologic features of the oligodendroglioma: the perinuclear halos, the fried egg cells. This one is not necessary now or sufficient to diagnose the oligodendroglioma. We must found this genetic mutation. The oligodendrogliomas have only two grades, the grade 2 and grade 3, never grade 4. The previous term anaplastic oligodendroglioma is no longer applied now because there is no grade 4. And also, as the astrocytoma, the same genetic mutation, if it is found in the oligodendroglioma, also it is uh, 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 consistent with or correlated with a poorer prognosis, even if there is no histologic evidence of the aggressiveness. Still, the aggressive features are not existing yet, but with this co-deletion, this tumor will be a very poor prognosis, and the treatment will be more aggressive than the other grades. The imaging findings of the oligodendroglioma, it love to be in the periphery of the brain, cortically based, poorly circumscribed, have the famous or the common calcifications. And it was reported that the lesion is heterogeneous in 96%, the calcification happened in 88%, and the enhancement is not so common, only in 50%. And there is a case here for the oligodendroglioma. You can see it in the periphery of the brain, cortically based, and there is calcification in the CT, and the enhancement pattern according to the grade, it is in this grade 3, you can see the enhancement is more heterogeneous and larger lesion, and you can see also the heterogeneity here is more in the grade 3. And the last adult type of glioma is the famous glioblastoma. Historically, this glioblastoma was divided according to it is de novo as a primary, or it is secondary, progressed from other lower grade glial tumors. And these glioblastomas have features of mitotic activity, microvascular proliferation, and necrosis. In 2016, the fourth edition of the WHO grading system, as I told you, they graded it as IDH gene mutations if it is mutant or the wild type. But recently, in the last edition, the fifth edition, the glioblastoma is only including the IDH wild type genetic mutation. The mutant was under the astrocytoma now, and there is also some certain features of the glioblastomas. There is other gene mutations like here, and the glioblastoma must have this IDH wild type genetic mutation and these other features of the genetic testing. If there is any new tumors, as I told you, or we cannot classify this tumor, they put it under not otherwise specified or not elsewhere classified. And there is a subtype of the glioblastoma is the gliosarcoma. It was a subtype of the glioblastoma in 2016, but now it is independent tumor type. In 2021, the fifth edition, the gliosarcoma become independent tumor type. And the fact that the enhancement is not correlated with the aggressiveness or higher grade of the tumors. Not always this is the rule. Sometimes there is a higher grade tumors, but it is not so enhancing. You can see here an example of the glioblastoma also in the left temporal lobe. And you can see the classic ring enhancement sign, the surrounding vasogenic edema causing the mass effect, facing the ipsilateral lateral ventricle, slight midline shift. And for the diffusion restriction from the periphery, not like the abscess that had the diffusion restriction inside it. Another case of glioblastoma also, you can see it here. It was in the past, this patient was classified as anaplastic astrocytoma, but now there is no existing tumor by the name of the anaplastic astrocytoma and needs to be reclassified, and it is classified as a low-grade glioma, and not also the lack of enhancement. Now we finished the adult types. We will have a brief talk about the pediatric gliomas. If you remember this classification, we have low-grade pediatric and high-grade pediatric gliomas. And this is a brief table for capping the most important things. And you can see also there is another types of mutations according to the subtype of the tumors. Let's talk about the low grade first. We have 4 subtypes: diffuse astrocytoma, angiocentric glioma, and the polymorphous neuroepithelial tumor of the young, and lastly, the diffuse low-grade glioma. And remember, all of these types are low-grade gliomas for the pediatric age group. The first one is the diffuse astrocytoma. It is a rare tumor, and it is always a grade 1. It is always a grade 1 tumor, and it is newly introduced to the 5th edition. It is related to this certain genetic mutations. And the most common presentation of this tumor is seizures, and hopefully it is surgically curable. After the tumor removal, the seizures stop. For the imaging features, it is mostly a supratentorial one. Most of the lesions are T2 hyperintense, T1 hypointense. There is no enhancement. It is well circumscribed, and sometimes it has cystic components. You can see this diffuse astrocytoma here in this very young child. The first images are when the patient was 2 years old, and it was non-enhancing, but it was well circumscribed and diffuse. There is surrounding also edema. After treatment, and when the patient reached the 9 years old, they were following up this lesion. It has new cystic components, and now they put it under the classification of the low-grade diffuse astrocytoma according to the genetic mutations. The second one was the angiocentric glioma. Also, it is a rare tumor. It is associated with epilepsy and also associated with these certain gene mutations. It is always, again, grade 1. It is peripherally located, supratentorial. As I told you, T2 hyperintense, most of the tumors are like that. There is no enhancement also, but it has a very characteristic appearance that it has a ribbon-like intrinsic T1 hyperintensity, and we can see it in these images. You can see in the T1, there is a hyperintense rim-like in the T1 pre-contrast, and it is not so enhancing in the post-contrast because it is high also in the T1, and you can see it also here in the T2. And this is characteristic feature of the angiocentric glioma. The third subtype of the low-grade pediatric gliomas is the polymorphous neuroepithelial tumor of the young. This is also a new tumor introduced in the 5th edition, and it is also grade 1. Has a certain type of mutations. This expression genes, and also there is activation factors related to this certain type of the glioma. The imaging, it is mostly in the temporal lobes and mostly have peripheral cysts and some calcifications. So it has some features like the oligodendroglioma, but by the genetic testing and molecular diagnosis, it is different from the oligodendroglioma. As I told you, the oligodendroglioma needs to have the co-deletion of that two genes that we saw in the beginning of the lecture. And this polymorphous neuroepithelial tumor of the young has another genetic mutation and another molecular testing. So it is now very important to know the genetics and the molecular diagnostics of the tumors. You will reclassify them according to these features, not only the imaging. And see, it is peripheral here, it has cystic component and the calcification, and the enhancement is only limited to the periphery, and it looks like the oligodendroglioma very much. The last one of the low-grade gliomas, pediatric gliomas, is the diffuse glioma. And it is also a new tumor. It was first presented in the fifth edition of the 2021. And it is also characterized by certain alterations or genetic mutations. It is morphologically looks like the astrocytoma or oligodendroglioma, and it can occur anywhere through the craniospinal axis. And in the future, it will be subdivided to other subtypes. They still don't know much about this type of the tumor. And as I told you, it has the same features of the astrocytoma and oligodendroglioma. And they still need to know more about this type of the tumors. And now the last subtype we will talk about it today is the pediatric gliomas, but the high-grade pediatric gliomas. As you see here, it has also 4 subtypes, like the low-grade diffuse midline glioma, diffuse hemispheric glioma, infant hemispheric glioma, and the diffuse high-grade glioma. But unfortunately, it has a very poor prognosis, and most of the cases has a very low lifespan, even with treatment, and there is no such curable tumor from them. And let's start by the diffuse midline glioma. It was first introduced to the classification in 2016 and named as infiltrative midline tumor. It has certain types of mutations also. And in 2021, it has more molecular features identified, and always it is ill-defined infiltrating contain tumors in the images. In the histopathology, as I told you, it has certain types of mutations, and it is always poor prognosis and always assigned for grade 4 tumors. Most of time, or most of the cases, they found it in the brainstem, thalamus, or the spinal cord. So it is always in the midline. And it is non-enhancing. So the enhancement is not a clue for the aggressiveness, not always related to the aggressiveness. See this pons diffusely increased in size, and you can see it also in the sagittal views. It is not non-enhancing. You can see the basilar artery inside the mass itself, and this is a very poor prognosis and a very aggressive tumor type. There is another case here. It is maybe epicentered on the thalamus. You can see it very aggressive, very heterogeneous, and there is no such curable tumor. The second subtype is the diffuse hemispheric glioma, so it is not midline. This is a new tumor introduced. It is aggressive and infiltrating, and it is always supratentorial in older children or young adults, always grade 4. All of these high grade gliomas are grade 4. The pathognomonic molecular features of it, that it is different from the previous one, that it has no histone 3 protein, and it has no, the IDH mutation is never present. Okay, so it is supratentorial but not midline. This is the diffuse hemispheric glioma. Also, it has aggressive features, necrosis, infiltration, enhancement. It has also the restricted diffusion pattern, and it can have leptomeningeal contact or leptomeningeal spread. And you can see here, it is in touch with the folks, and it has cystic components and calcification, and it is enhancing. It is dural based, and it is very, very aggressive one. The third one is the infant hemispheric gliomas. It is often presenting in the first year of life. It has certain types of mutation, is the receptor tyrosine kinase fusions, and by the imaging, it is also have leptomeningeal dissemination or leptomeningeal spread. Histopathologically, it is cystic and solid component with necrosis and hemorrhage. You can see it here. So it is presenting in the first year. See this baby is 5 months old, and you can see it have multiple cystic components, calcifications, and causing large hydrocephalus also. And it is very poor prognosis. And the last one will be the diffuse high-grade glioma, and it is newly described in the 5th edition. It is aggressive, but lack also the mutations of the IDH or the histone 3. Histologically, it is poorly differentiated. It has a microvascular proliferation and necrosis. Of note, most pediatric radiation-induced high-grade gliomas are containing this certain type of mutation. So if it is radiation induced, it will have this certain type of mutations. If it is de novo, it will be lacking this certain type of mutations. And it looks like the adult glioblastoma. You can see it here. It is not so aggressive on the imaging, but still it is high grade. So don't forget that. I finished the first part now, and we will talk about the second part in the future lectures. If anybody have any questions, feel free to ask. I hope you enjoyed the scientific day, and I think it will be a good start for such monthly meetings or quarterly meetings. It will be a very nice idea to continue on it. And if you have any ideas or any suggestions, also feel free to send it to us. Again, thanks to all of you, and I hope you enjoyed it.